All right, we are going to move on and talk about skiffies to start. So in this first question, the most important things that I really want you to pay attention to are the age of this patient. This is a 12-year-old male with right knee pain. And you're provided essentially with some images and a growth chart. So what they want to know is what you would do next. So here are the images. Images are essentially a normal knee x-ray. And your growth chart right here shows a obese patient with a normal height. So obese patient, knee pain, and normal x-rays. Immediately, hopefully your spidey sense is going up and you're thinking that this is someone that we need to look at closer, and hopefully we want to look at their hip and pelvic radiographs, which is the preferred response. So it's really important in any overweight adolescent patient with knee pain who has normal knee images to consider their hip. And that's what this question is getting at. So here's another question. Adolescent boy who is also overweight with bilateral thigh and knee pain after falling off of a trampoline. So minimal trauma, ongoing complaints of bilateral thigh and knee pain. And you're provided with a series of images which are here. So what these are showing you, these are AP and frog views of the pelvis, and you can see very clearly that he has a right slip capital femoral epiphysis. More subtle, though, is this left slip capital femoral epiphysis, and that's better appreciated on the frog. And you're provided with knee images, which are essentially, again, normal. So this is a child who has bilateral slip capital femoral epiphyses, and the goal to treat these would be to treat them quickly and with in situ pinning, which is the response number 1. So just an introduction, you can see if you look up here, skiffy, super frequently tested, one of the most frequently tested hip conditions, so this is really important. It's a disorder of the proximal femoral physis that results in the metaphysis slipping relative to the epiphysis. So we were all taught in medical school the ice cream falls off the cone, but in reality, now that we're fancy orthopedic surgeons, we know that the ice cream stays in place and it's actually the cone that moves relative to the ice cream. It's the most common disorder that affects adolescent hips, occurs in 10 out of 100,000 patients. We see this more commonly in obese patients, and obesity is the biggest risk factor for this. Male to female ratio is about 3 to 2, and there are specific ethnicities, especially African Americans, in which this is more common. Typically, this occurs during periods of rapid growth, so adolescent patients are most commonly affected by this, typically between 10 and 16 years of age. The average age for boys is around 14, and average age for girls is about 12. Left hip is more common than the right, and we have no idea why that is, but in general, most hip conditions are more common on the left than on the right. And we see this bilaterally in somewhere between 17 and 50%, depending on the population that we are looking at. Now, the most important risk factor for slip capital femoral epiphysis is obesity. So recent data showing changes in who we're seeing skiffies in, and we think this is probably related to increasing rates of childhood obesity. You can also have mechanical risk factors, including femoral or acetabular retroversion, and of more historical significance is radiation to the femoral head region. Patients typically will present with groin pain. Approximately 50% of patients will present with pain around their hip, either in the groin or greater trochanter, and about 25% can present with knee pain. And scarily, about 8 to 10% can present with a relatively painless limp. Now, the reason why thigh and knee pain are common presenting symptoms is because irritation from the obturator nerve as it passes over the hip capsule can lead to referred pain on the medial thigh and medial aspect of the knee. This can lead to misdiagnoses, and that's a really important factor to keep in mind. So in general, when you see these patients, they prefer to sit in a chair with their affected leg crossed over each other, or they slouch in their chair secondary to limited hip flexion. Symptoms have usually been present in these patients for a prolonged period of time. So the most recent study that's come out about delay in diagnosis shows that patients have had symptoms for an average of 17 weeks before their symptoms were identified as being secondary to a SCFE. On physical exam, these patients are going to present with some type of gait abnormality. Most commonly, you're going to see an external foot progression angle, but you can see antalgic or waddling gaits, Trendelenburg gaits, etc. Most of these patients, in fact, all of these patients are going to show decreased hip range of motion. Most significantly, they're going to show obligatory external rotation during passive flexion of the hip, or limited internal rotation when you attempt to flex them up. And this is secondary to the metaphysis having moved anteriorly and superiorly compared to the epiphysis. You're going to see a loss of internal rotation, a loss of abduction, and a loss of flexion in these patients. You're going to see some abnormal leg alignment, specifically externally rotated foot progression angles, and this is again secondary to the displacement of the metaphysis while the epiphysis stays in place. And these patients can often demonstrate some thigh atrophy or weakness around the muscles. So on to our next question. Again, we have an adolescent male with hip pain and inability to ambulate. His initial x-rays are shown here, and I'll click to those in a second, but the goal of this question is to figure out what zone of the growth plate is most commonly involved with this condition. So the first part of this question is to identify that this is indeed a slipped capital femoral epiphysis. And then the next most important part of this question is to realize that SCFE occurs through the zone of hypertrophy. And then even if you can easily figure out that it occurs through the zone of hypertrophy, you then have to know what the zone of hypertrophy looks like. And the answer to this one is D. This is the zone of hypertrophy. So in general, the pathophysiology of slipped capital femoral epiphysis, it's due to abnormal mechanical forces acting on a sick physis. So you have an abnormal physis and abnormal mechanical forces. You need both of these components to create a slip. The slippage tends to occur through the zone of hypertrophy, or the hypertrophic zone of the epiphysis. This is also the same place where rickets and the dysplasias tend to occur. This is the slide of the growth plate. And so here's your growth plate. Here's the hypertrophic zone. And what you notice is that chondrocytes here are very large. They're about 5 to 10 times the size of the chondrocytes in any other region. And that's how you're going to identify it histologically. In adolescence, the perichondrial ring thins and your mammillary processes unlock, and you still have a pretty vertically oriented physis as you're heading towards skeletal maturity. So all of these things combine to weaken the physis and increase shear forces across the physis. You also have an epiphyseal tubercle, which is actually kind of a peg from the epiphysis, which comes down and locks into a corresponding hole in the metaphysis. That starts to shrink when you get close to maturity and can also lead to risk for slipped capital femoral epiphysis. The cartilage in the hypertrophic zone is your weak spot. So what happens is that your metaphysis translates anteriorly, it externally rotates, and it moves superiorly. Your epiphysis stays in the acetabulum. So remember, ice cream stays and cone is what moves. This is similar to a Salter-Harris 1 fracture of the proximal femoral physis. The difference here is you have a prior sick physis, so your physis is abnormal in a SCFE. You tend to have a normal physis when you have a Salter-Harris 1 fracture. The displacement tends to be much slower, and there tends to be remodeling present. And in chronic slips, your periosteum can even be intact. Acute severe slips, your periosteum can be torn anteriorly, just like in a Salter-Harris 1. So there are several conditions that are associated with slipped capital femoral epiphysis. The most important to look for is probably the endocrine disorders. Most commonly, we're going to see hypothyroidism. And to diagnose this, you'll see an elevated TSH. This can also be associated with renal osteodystrophy, which is actually shown here. This x-ray is a patient with renal osteodystrophy. And these patients demonstrate an elevated BUN and creatinine. Patients can also have a growth hormone deficiency, or they can be receiving exogenous growth hormone, or they could have panhypopituitarism. Patients that you want to consider for an endocrine workup include young children or children whose weight is below the 50th percentile by BMI for their age. In addition, patients with Down syndrome are at increased risk for slip capital femoral epiphysis. So our next question, we have, again, an adolescent obese male, and we know this time that he has a SCFE. So this question is asking us to determine what radiographic findings we use to determine severity. So here are the images that are given to you. And interestingly enough, only the first two of these even have anything to do with slips. These three should be familiar from Dr. Sink's talk just a few minutes ago. So the first two are the Southwick angle and Klein's line. And the answer here is the Southwick angle. So the Southwick angle is a measurement to determine slip severity, and we'll go over how to do that. Patients, in general, when you suspect a slip capital femoral epiphysis, you want to get AP and frog views of bilateral hips. The frog lateral is probably the best way to identify a subtle slip. What you're going to look for first is Klein's line, and this is a line that's drawn along the superior border of the metaphysis, and it should intersect with the epiphysis, as seen here. If the epiphysis is not beyond Klein's line, then you have a slipped capital femoral epiphysis, as shown here, and you can do this on either the AP or the frog view. Now, an MRI is indicated in patients where you have a high index of suspicion for a slip capital femoral epiphysis, but that their x-rays appear normal. This can help you diagnose what we call a pre-slip condition, or a hip that's getting ready to slip. And what you'll see in these MRIs are growth plate widening and edema around the metaphysis. So our next question, we have an adolescent female now. She's had 6 months of groin pain after she was already treated for slip capital femoral epiphysis. So her preoperative radiographs we have, and then her postoperative radiographs at 6 months are seen. And again, this question is asking us two parts to identify what the complication that's occurred here is and what her risk factor was for it. So you can see here a severe slip capital femoral epiphysis, and then so here's your severe slip capital femoral epiphysis. And then what you're seeing here is avascular necrosis with collapse of the femoral head. So in the stem, the thing that put her most at risk for getting avascular necrosis after her in situ pinning was that she was unable to bear weight even with an assistive device. So this indicates an unstable slip capital femoral epiphysis and puts her risk for avascular necrosis something near 50%. So this leads us into the discussion of the Loader classification. This classification indicates whether a slip is stable or unstable. Stable slips, you can bear weight with or without crutches. And these patients have a minimal risk of avascular necrosis. In some series, 0%, and somewhere around 5 to 10%. Unstable slips are patients who are unable to ambulate, not even with crutches. These patients have a very high risk of avascular necrosis of the femoral head. So originally, Dr. Loader put this number at almost 50%. Recent data puts this down more like a quarter of these patients. And this information is important because it can provide you with prognostic information for your risk of AVN. So we're back to the Southwick angle. And this question is asking what purpose it serves. Now, if we paid attention in the last question, we know that it's going to determine the severity of the slip, which is the answer. So how do we check, or how do we determine what the Southwick angle is? This is based on the epiphyseal diaphyseal angle and the difference of that to the contralateral or normal side. So this was traditionally done on the frog view, but it can also be done on the AP view. And essentially, your classification is mild if it's less than 30 degrees, moderate if it's 30 to 50 degrees, and greater than 50 degrees we consider severe. So if you have bilateral involvement, you can use 145 degrees as your hip reference on the AP and 10 degrees on the frog lateral. There's a grading system, the Wilson percent displacement, and this gives you a grade 1, 2, or 3 based on the percentage of the femoral neck that is uncovered when the head slips off. So 0 to 33% is grade 1, 34 to 50% is grade 2, and greater than 50% is grade 3. So our next question is asking about treatment. So where is the starting point for in situ fixation for a slipped capital femoral epiphysis with a Southwick angle of 20 degrees? Now we know, because we're super smart and we just went over this, that a Southwick angle of 20 degrees is a mild slip. So where are we going to start our pin? So first thing we know is that our metaphysis displaces anteriorly, and that puts our epiphysis behind. So we know that we're not going to want to start our screw behind because our epiphysis is already back there. So we already know these two we can rule out. Now, these two we can rule out because they're both posterior. Now, if we choose this starting point or this starting point, we will not wind up center in the epiphysis because we know that the epiphysis is behind. So in order to get to center on the epiphysis, we have to start anterior on the femoral neck. So first treatment goal is to stabilize the epiphysis from further slipping and to promote closure of the proximal femoral physis. Now, in order to do in situ pinning, we do not want to forcefully reduce the hip. We don't mind a quote-unquote serendipitous reduction, and we often get that from positioning the patient on the OR table. But we don't want to forcefully reduce the SCFE as it can increase intracapsular pressure and therefore increase your risk of developing avascular necrosis of the femoral head. Now, number of screws used to treat tends to be controversial, but a single cannulated screw is almost always sufficient, and it decreases the risk of AVN compared to multiple screws. Percutaneous in situ fixation can be used in both stable and unstable slips, and like we just mentioned, 1 versus 2 screws is controversial. 2-screw constructs can be more biomechanically stable, but we want to wind up center in the femoral head. That's where the bone is. That's where the bone is good. You can't have 2 screws center in the femoral head. You want your screw to be perpendicular to the physis as much as possible, which is why you start on the anterior surface of the proximal femur. So that question that we were going over before, anterior surface of the proximal femur. And most importantly, you do not want to be medial to the intertrochanteric line, as this can increase your risk for screw head impingement on the acetabulum when the hip goes through range of motion. For patients who have a significant amount of deformity, you may have to make your screw more oblique, and the goal still is to get your screw center in the epiphysis. You want to have at least 5 threads across the physis, and previous studies have shown that's the most stable construct, but you want to make sure that your screws are at least 5 millimeters from the subchondral bone in all views. And so the way that you can do that is with your fluoroscopic imaging. So you can rotate the hip. We do an around the world technique here where we rotate the hip from maximal internal to maximal external rotation and find the view where the screw looks closest approach to the joint. You can use a fracture table to help with good radiographic visualization. Here we actually do it on a Jackson table. Stable slips, we generally allow to bear weight right after they're fixed, and unstable slips, we generally keep touchdown weight bearing for about 6 weeks. So the rule of thumb is, if you could bear weight beforehand, you can bear weight after. Outcomes for in situ screw fixation are generally good, but this doesn't address any kind of deformity that you have afterward secondary to your slip. All right, so our next question. We have a 10-year-old African-American boy who has right hip pain with symptoms for 1 week. And again, he's an obese patient. So here are our images. And what we're seeing here is a severe slipped capital femoral epiphysis. Sorry, I keep forgetting to move the cursor. Severe slipped capital femoral epiphysis. So what the question is asking is, would you recommend prophylactic treatment because of which of the following things? Are any of these not risk factors for contralateral slip? And in this patient, we would recommend it, and the only thing that was listed there that would not lead us to go for prophylactic pin fixation is the short duration of symptoms. So our indications for contralateral hip pinning is still controversial, but we want to do this in high-risk patients. So the most important factor that we consider is young age at initial slip. So my cutoff is generally 10 years old. Patients with endocrine disorders are another group that you really want to consider contralateral pinning in, and the rest of these are actually just staging that indicates skeletal immaturity. All right, so we have an adolescent girl with right hip pain, and we're going to guess that our images show a slip, and her TSH is 11, so her TSH is elevated. So that's telling us that she has hypothyroidism, and they're asking what the most appropriate treatment recommendation is. So is this someone who needs prophylactic pinning? And because of her endocrine abnormality, we would in fact recommend pinning both sides, even though she only has a slip on one side. Her risk of contralateral slip is much higher than the general population with SCFE, and thus you want to try to prevent that when possible. So other operative treatment options, you can do open epiphyseal reduction and fixation, and you want to consider that in unstable or severe slips. And we're going to go over in a little more detail the modified Dunn procedure in a few minutes. You can consider an osteochondroplasty for mild or moderate SCFE deformities, and we'll go over that again in a minute. And you can consider proximal femoral osteotomy in already treated slips for painful or function-limiting problems. So let's talk a little bit about the modified Dunn procedure. The goal of this is to correct the proximal femoral deformity acutely. We do this through a surgical hip dislocation approach. We make a Z-shaped anterior capsulotomy. Temporarily, we're going to pin our epiphysis to allow us to dislocate the hip safely. And then we're going to develop retinacular flaps, and we want to do this circumferentially around the neck and extend this distally down to the lesser trochanter. We want to do this very gently, and we're going to develop these periosteal flaps bluntly. And then if our epiphysis is not freely mobile, we're going to mobilize it. At this point, we'll also take out our pin that we placed prophylactically. Your epiphysis stays attached to the posterior retinacular blood supply. It's very important to remember this and to ensure that, that you're protecting this throughout this procedure. You want to gently debride your metaphysis. Most of your callus is going to be posterior and medial, and remember your retinacular flap is back there, so this has to be done carefully. But you want to debride the callus in order to allow for a reduction of the epiphysis with minimal tension on your retinacular flap. And then you're going to reduce your epiphysis to your metaphysis. In general, we fix this with a single pin through the fovea, antegrade, and then I use 2 4-5 fully threaded screws for this. You can use K-wires, fully threaded K-wires, if you want. One of the possible benefits here is that it could reduce your intracapsular hip pressure and can decrease your intracapsular tamponade. I do touchdown weight bearing for 6 weeks. Now, the biggest complication with modified Dunn is AVN. AVN rates that are reported in the literature most recently are somewhere around a quarter of patients who undergo this procedure, and this is pretty comparable to about a quarter of patients with unstable slip capital femoral epiphyses. So they're relatively equal. These procedures have a very steep learning curve. Dr. Sankar and his group, they showed that these procedures should be done by people who are doing them frequently and with a relatively high volume, as they do have a very steep learning curve. Osteochondroplasty, the goal is to address loss of motion in patients with mild to moderate skiffy deformities. This can be done through arthroscopy for very mild deformities. It can be done through a limited anterior arthrotomy, again, for more mild to moderate deformities. And then patients with moderate to severe deformities, it can be done through a surgical hip dislocation approach. And this can be combined with a proximal femoral osteotomy at the same time. We don't really have much long-term data on how these patients do. It does improve their pain and function immediately, but most of these patients with slips have pre-existing cartilage damage from the time of the injury and from ongoing impingement, and those patients tend to have poorer outcomes. Flexion intertrochanteric osteotomy, or the Imhauser, can correct some symptomatic, especially decreased range of motion. It doesn't actually address the deformity at its location, but it does address it in a safer place. So this is a lateral approach. You do a straight transverse intertrochanteric osteotomy and reposition the femur, do flexion, internal rotation, and a very small amount of valgus. These patients are touchdown weight bearing for somewhere between 8 weeks and 3 months, depending on their healing and their age. And these patients tend to do very well functionally with a low rate of AVN. So let's go over the next question. 12-year-old male, again, adolescent male, 4 days of groin pain and inability to bear weight. We know that he has a slip because this is the slip section. He's got x-rays from 1 week and then 8 months. And these are his x-rays. And they show a severe slip capital femoral epiphysis again, 2 screws at his 1 week visit, and then you can see complete or near complete collapse of the femoral head with loss of joint space and a high riding greater trochanter. So this is another patient who developed avascular necrosis of the femoral head. So avascular necrosis of the femoral head is probably the most devastating complication associated with slip capital femoral epiphysis. It can result from the initial trauma or from an operative complication, depending on your treatment technique. In in situ pinning, posterior superior screws are the most associated with disrupting the blood supply. Contralateral slips can happen after a unilateral slip, and the risk factors we already talked about, for the most part, young patients and endocrine disorders. Dr. Coker and his group at Boston Children's recently published a paper that showed that decreasing your BMI can decrease the rate of subsequent contralateral slip capital femoral epiphysis. Chondrolysis can happen. This is a narrow joint space and decreased range of motion. And most commonly, this currently happens from unrecognized implant penetration. So when you put your guide pin into the joint, you increase your risk for chondrolysis. And then if your screw penetrates, you have an even higher rate of chondrolysis. Historically, spica cast immobilization and multiple pin fixation were also associated with chondrolysis, but these are not ways that we treat slips anymore. Probably the most common complication from slip capital femoral epiphysis is residual deformity. So because your metaphysis slips anteriorly and superiorly, you will wind up with a metaphyseal bump. In some patients, this remodels, and in others, it doesn't. When it does not remodel, you essentially develop a cam lesion and develop cam-type impingement. And this can be treated, as we talked about, osteochondroplasty, either through a scope or with anterior approach to the hip and open osteochondroplasty or a surgical dislocation, or it can be treated with proximal femoral osteotomy. Slip progression can occur, but it's rare. It occurs in about 1 to 2% of cases with single screw fixation. And delayed diagnosis, we actually touched on earlier, but the literature basically shows that delayed diagnosis can be anywhere from about a month to up to about 17 weeks. So 17 weeks was the average delay in diagnosis that we most recently found when we looked at this. And things that can contribute to delay in diagnosis are knee pain, if the slip is stable, and poor insurance. There can be proximal periprosthetic fractures and labral degeneration, as we talked about before.
If you enjoyed this video, please consider leaving a like. We'd love to hear your thoughts and what you'd like to see next in the comments. Don't forget to subscribe to our channel and follow us on social media.